Hi everyone, just a quick reminder before we get started. All the information here is based on standard textbooks and is for your exam preparation. It's not a substitute for professional medical advice. Hello, future doctors, and welcome back to Bedside Clinics. So in our last session, we went through the complete history taking for a patient with swelling. If you haven't seen that one yet, definitely check it out. The link is down below. Today, we're moving on to the next crucial step, the part where everything starts to come together, the physical examination. This is without a doubt a core skill you'll use every single day on your ward rounds and your final exams, and of course, it's absolutely key to acing your OSCEs. So let's jump right in. Okay, so here's our game plan for today. First, we'll quickly touch on why the physical exam is so incredibly important. Then, I'll give you the systematic approach that you must follow. After that, we'll break down each step, inspection, palpation, the whole shebang. Then comes the exciting part, a live demonstration with a patient. And to finish up, we'll talk about how to present your case perfectly for an OSCE, and I'll share some common mistakes to avoid and a few pro tips to make you look like a star. All right, let's start with the big why. I mean, with all the fancy technology we have today, MRIs, CT scans, you might be wondering, is the good old physical exam even that important anymore? Well, let me tell you, the answer is a huge, unequivocal yes. You see, all the major textbooks, DAS, Maheshwari, Apley, they all agree on this one thing. A good history, combined with a proper physical examination, gets you to the right diagnosis about 70 to 80% of the time. Just think about that for a second. That's massive. This is the bedrock of what we do. Your investigations, they're meant to confirm what your hands and eyes have already told you, not to be a fishing expedition. So the bottom line is, your clinical skills are your most powerful tool. Master them. Okay, so how do you make sure your examination is solid every single time? The secret is simple. You have to be systematic. This isn't the time to freestyle or improvise. You need a rock-solid method, a checklist in your head that you follow religiously for every single patient. It's like a pilot's pre-flight check. It ensures you don't miss anything, ever. And this is the sequence. Burn it into your memory. It goes inspection, what you see, palpation, what you feel, then come measurements and special tests, followed by movements and the all-important neurovascular status check. And you always finish with the regional lymph nodes. I'll say it again. Inspection, palpation, special tests, movements, neurovascular, lymph nodes. Do not change this order. Okay, let's break it down, starting with step 1, inspection. Honestly, this begins the second your patient walks into the room. It's all about training your eyes to be sharp and notice the details. So what are you looking for? Well, even before they get on the couch, watch them walk. What's their gait like? Then notice the attitude of the limb. How are they holding it? Are they protecting it from pain? Okay, now they're on the bed and the area is properly exposed. Look at the swelling itself. Where is it exactly? What's its size? Its shape? Then get closer. Look at the skin over it. Is it red, shiny? Are there any old scars or sinuses? A sinus can be a dead giveaway for something like chronic osteomyelitis or even TB. And finally, take a step back and look for the bigger picture. Any deformity or muscle wasting compared to the other side. Right, we've used our eyes, now it's time to use our hands. We're moving on to palpation. And a golden rule here, always start with the normal, unaffected side first. This does two things. It gives you a baseline for what's normal, and it helps build trust with your patient. First, use the back of your hand to feel for temperature. Is there any warmth? Next, gentle palpation for tenderness. Start away from the swelling and move closer, trying to pinpoint the area of maximum tenderness. Now, what does it actually feel like? What's the consistency? Is it soft like a lipoma? Is it cystic, feeling like a little water balloon? Or is it firm like a fibroma? Maybe it's even rock hard, bony hard. Pay attention to the edges. Are they well-defined or are they diffuse and irregular? That can be a really important clue. Check its mobility. And then, two really important tests. 1, the fluctuation test. If it's fluctuant, you know there's fluid inside. And 2, if it's fluctuant, try transillumination. A little torch in a dark room can tell you if that fluid is clear or not. Okay, after the general palpation, we move on to special tests. These are more targeted maneuvers that help us confirm what we're suspecting. The knee is a classic example when it comes to swelling, so let's use that to see how these tests work. So for the knee, if you're suspecting an effusion, that's fluid inside the joint, your bread and butter test is the patellar tap. If you feel that tap, it confirms you have a significant effusion. If you think there's only a small amount of fluid, the fluid wave test can be more sensitive. For swellings outside the joint, like a prepatellar bursitis, you check for cross fluctuation. And finally, something you must always do, measure the girth.
Get out your measuring tape, pick a fixed bony point, and measure the circumference. Compare it with the other side. This gives you cold, hard numbers, an objective way to track the swelling or any muscle wasting.
Now, it's pretty obvious that a swelling near a joint is going to affect how that joint moves, right? So the next logical step is to assess the movements. This tells us about the function of the joint. And we check this in two ways. First, active range of motion. You ask the patient, can you move your knee for me? Then, passive range of motion. You gently move the joint for them. And all the while, you're looking for a few things. Is there pain? Is the movement restricted? And place your hand on the joint. Do you feel any crepitus, that grinding or crackling sensation? And of course, if the history suggests it, this is where you'd perform your instability tests to check the ligaments. All right, listen very carefully now. This next step is non-negotiable. You can never forget to check the neurovascular status. A large swelling or one from trauma can easily compress the nerves and blood vessels downstream. Missing this can lead to devastating, limb-threatening consequences. It's that serious. And what are you checking? It's a simple three-part check, always distal to the swelling. First, feel for the pulses. For the knee, that's your dorsalis pedis and posterior tibial. Second, check the sensation in the foot. And third, test the motor power. Ask them to wiggle their toes, move their ankle. You need to be able to confidently say and document that the distal neurovascular stratus is intact. And we're at our final step, checking the regional lymph nodes. Think of them as the sentinels of the lymphatic system. For a leg or knee swelling, you'll be palpating the inguinal nodes. Why? Because if they're enlarged and tender, it points towards an infection. But if they're hard, matted, and non-tender, that's a red flag for malignancy. It's a simple but vital part of the exam. Okay, theory is one thing, but seeing it done is another. Let's put all this together now in a live demonstration. I have a patient here with me, a 25-year-old gentleman who came in with a swollen right knee after a fall. Let's go through the examination step by step. So first up is inspection. As he walked in, I noted an algesic gait. He's clearly limping on that right leg. Now, with both knees exposed, I can see a pretty obvious swelling over the right knee, mainly in the suprapatellar area. I'd estimate it's about 8 by 6 centimeters. The skin over it looks completely normal though. No redness, no scars, no sinuses. Okay, moving on to palpation. First, temperature. Yes, the right knee definitely feels warmer than the left. Now for tenderness. Gentle pressure, and yes, he's tender, particularly on the medial side here. And the swelling itself, it feels quite tense, and it is definitely fluctuant. That tells me there's fluid in there. Time for special tests. Given the history and the fluctuant swelling, I'm going straight for the patellar tap. So I'll just milk the fluid down from the suprapatellar pouch and tap. There it is, that unmistakable click of the patella hitting the femur. That is a positive patellar tap, and it confirms our suspicion of a large effusion inside the joint. Okay, so I've also checked his movements, which are painfully restricted, and confirmed his distal pulses and sensation are normal. So let's put all the pieces together. We have a young man, a clear history of trauma, a warm and tender knee, and a positive patellar tap confirming fluid. This clinical picture is classic for an acute post-traumatic hemarthrosis. That's a fancy way of saying he has bleeding inside his knee joint.
Now, doing the examination is only half the battle, especially in your exams. In an OSCE, you've got to present your findings to the examiner, clearly, confidently, and usually in under a minute. This is a skill you have to practice.
So, for our patient, a perfect 60-second summary would sound something like this. On examination of this gentleman's right knee, I found an 8 by 6 centimeter fluctuant swelling in the suprapatellar region, which was warm and tender. The patella tap was positive, range of motion was painfully restricted to 90 degrees of flexion, distal neurovascular status was intact. My provisional diagnosis is an acute hemarthrosis, and I would like to proceed with relevant investigations. See how that flows? It's systematic, it's concise, and it hits all the key points. You need to practice this format. Before we wrap up, let me give you a few final pointers. These are some of the most common mistakes I see students make, and a couple of pro tips that will really set you apart from the crowd. Okay, the big mistakes to avoid. Number 1, forgetting to compare with the opposite side. It's a rookie error. Number 2, seeing a soft swelling and not checking for fluctuation. And number 3, the absolute cardinal sin, skipping the neurovascular check. Please never, ever do that. Now for the pro tips. Always have a high index of suspicion for tuberculosis in our country, so actively look for things like a cold abscess or a discharging sinus. And my second tip, use a measuring tape. Don't just eyeball the size. It shows you're precise and professional.
And there you have it, our complete step-by-step guide to examining a swelling. I really hope you found that useful. In our next session, we're going to tackle some common OSCE stations involving swelling, so you'll know exactly what to expect. If any part of this was unclear, or if you have any questions at all, just pop them in the comments below. And of course, if this helped you out, please give it a like and subscribe to Bedside Clinics so you don't miss the next one.
Thanks for joining me today. Keep studying hard, and remember, practice makes perfect. This is all for your educational benefit, so always go back to your textbooks and your teachers. See you next time.